Okay, now we are going to go over chapter 12 of R&M, and this is scanning duplex and color flow imaging of the upper extremity arteries. So what are the capabilities? It's going to allow us to localize an arterial stenosis or occlusion and evaluate the degree of that stenosis. I want you to make sure you know the difference between a stenosis and an occlusion. A stenosis is going to be a blockage in an artery. An occlusion is when the entire artery is completely blocked. There's no flow going through the artery at all. So with a stenosis, there's a blockage, but there is still flow. An occlusion, no flow. With a stenosis, we will evaluate the degree of the stenosis. We will grade it mild, moderate, or severe. This is the same for the legs. More capabilities are, it's going to determine the presence or absence of an aneurysm. We're going to be able to evaluate a hemodialysis access graft or an arterial bypass graft. We're going to be able to detect arterial venous fistulas or other abnormalities and evaluate medical treatment or surgery on a follow-up basis. Limitations here, again, dressings, skin staples, sutures. For the arms, imaging around IV sites is really difficult, and it's almost every patient you're going to have in a hospital setting is going to have an IV, and basically you're just not going to be able to see around the area with an IV. Hemodialysis access grafts, they're difficult to assess the anastomosis sites because of the angle of the graft. Difficult to adequately evaluate outflow veins, secondary to increased collateral development. So how do we do this? Same position as always. For venous and arterial will be the same. Our patient is going to be laying on their back, pillow under the head. The extremity is going to be positioned close to the sonographer. I like to put a towel in my lap and or a pillow and have them put their hand on my lap. For dialysis graft, I always listen or feel. I like to feel for the bruit. If they have a dialysis graft in their arm, you will be able to put your hand on it and feel what we call a thrill going through. We use the same transducer that we've been using for lower extremity venous, arms, and lower extremity arterial, that 5 to 7 megahertz linear array transducer. The images we're going to get here of the arteries we're going to look at, I should say, are subclavian, axillary, brachial, radial, ulnar. Palmar arch if necessary. It gets really small, very difficult to view. We're not going to put it in our protocol. What you're going to do, you're going to do a grayscale image. The grayscale is going to help us observe vessel walls and identify any plaque or morphology. The Doppler is going to help us evaluate waveforms and measure our velocities. Our waveforms for the arms should be multiphasic, triphasic, like they are in the legs. A monophasic waveform, again, would indicate something abnormal. Color flow is going to help us decide which way flow is moving, any deviations or narrow channels or absence of flow. Okay, here is a picture of a brachial artery. You can see it's very similar to, say, your SFA in your leg. You're going to have a very high resistant triphasic waveform. Okay, how are we going to interpret this? A stenosis, again, a stenosis, you will have flow through the velocity, through the artery, but it's going to be a blockage. So the plaque, it has built up in the artery, causing a blockage or a stenosis. Your peak systolic velocities at that point are going to be really high. You can have changes in skin temperature will make things warm, will give you triphasic, higher resistant waveform. Cold will give you a lower resistance waveform there. An occlusion is going to give us absent Doppler signal. So when you see an occlusion, if you put your color Doppler and pulse wave Doppler on an artery that's occluded, there's just going to be no flow. It's very important to make sure you turn your color scale down, turn your color gain up to assure that there is no flow. Okay? And another thing is, before you get to the area of occlusion, when you're Dopplering, you're going to hear what's called a thump. You're going to get a monophasic waveform called a thump. It's literally going to sound like a thump on the Doppler. This is before proximal to an occlusion. An aneurysm is just going to be a dilation of the artery. So what we use in our clinic is, if you're scanning an artery, you see it dilate, a dilation is going to be significant if that segment doubles. So you're scanning along, everything looks normal, it is a bigger area at one point, measure it. Say your smaller area measures 0.5 centimeters, and then the dilation measures 3 centimeters. That is a significant aneurysm, as in it has doubled in size. There's also what's called hypothalamic hammer syndrome, and that's from using the ulnar artery. You can get an ulnar artery aneurysm from using the palm of the hand as a hammer. Subclavian artery aneurysm is often associated with embolization to digits. So watch out for those. Definitely don't use your hand as a hammer, because you can get a aneurysm in the ulnar artery from that. Okay, so when we are scanning a hemodialysis fistula or graft, now let me stop and explain what this is. Hemodialysis fistula or graft is something that the doctor is going to create in the arm. The doctor surgeon will take a vein, a superficial vein, either your basilic or cephalic, and they are going to tie it in to an artery. When they do that, when they hook your basilic or your cephalic vein to an artery, that cephalic or basilic will become arterialized. And what they do is use this for patients who are on dialysis. They will use this fistula, it's called a fistula, hemodialysis fistula. They will use that, they will stick that with the needle, and the patient will run dialysis through this fistula. Now, that fistula is when they take the patient's own cephalic or basilic and hook it into the radial or brachial artery. A hemodialysis graft is when the patient doesn't have a cephalic or basilic vein that is big enough, or maybe has a cephalic or basilic vein that has superficial venous thrombus in it. They will put a graft. They will take a foreign material, a tube, and hook it in to the radial artery or brachial artery. That will become the hemodialysis graft, where the patient will have dialysis access. Okay? So what you're going to do when you have one of these, they're very complicated, and you're not going to see these everywhere. They're really complicated, but try to keep it simple. So what you want to evaluate is the inflow artery, and that's the artery below where the doctor has hooked the vein to the artery. The arterial anastomosis is where the doctor has hooked the vein or the graft in to each other, where they have made the connection. That's the anastomosis. Then you will evaluate the graft, check for any aneurysms, puncture sites, fluid. We check for high velocities, turbulence. Then at the end, you'll have another anastomosis, the venous anastomosis, and then the outflow vein. Okay. Volume flow is really the main thing that the doctor is going to want to know. That's going to give you the rate of the volume flow going through the fistula, and that will indicate if the patient will be able to have a successful dialysis session. Okay, so this is a type of arteriovenous fistula. This is where you can see where they have taken the vein, which is going to be the patient's cephalic vein, and they've hooked it in to the patient's radial artery. They made a connection there. So that vein at that time is going to be the AVF. That will be the fistula. And that is where you can see the dialysis machine will take the needles and hook into that vein. All right. I know this is confusing. I don't want you to overthink it. I do want you to know when they hook in the cephalic vein to the radial artery, it's called a semino or a radiocephalic AVF, which stands for arteriovenous fistula. And here's another kind. Brachiocephalic AVF is where they take the patient's cephalic vein and hook it in to the brachial artery. And I just want to add, you want to, when we do a vein map, where we will go in and it's its own test before a patient gets a fistula, we will go in and we will measure the basilic vein, we will measure the cephalic vein all the way down the arm. The surgeons want it to be at least 0.3 centimeters or bigger. Our surgeons at least want 0.3 centimeters or bigger in order to have a successful surgery. So if the patient has that, ideally you want to start, if you're going to create a fistula, you want to put it as low as possible, as in you want to do a semino where you hook in the cephalic vein to the radial artery, because once you create a brachiocephalic in the upper arm, you can't go back down and create a radiocephalic. And that is important because this is this patient's lifeline, this fistula. When you are on dialysis, this is your lifeline. They will go to dialysis 3 times a week, and it's what's keeping them alive. So when you create, again, you want to start at radiocephalic down in the forearm. If that fails, because you'll get a lot of problems with these fistulas. They're hard to keep. They get stenotic. They get blockages. They get aneurysmal. They're hard to keep. When that one fails in the forearm, you can move up to the upper arm. However, if you start and put a fistula in the upper arm, you cannot go back to the forearm. You can't go backwards. So you only have so many options. You only have 2 arms. They can do these in the leg, and then there are some they can do in the stomach, but you only have so many options. So it's really important when you're doing the vein map, you have light pressure on these veins. You know they're very close to the skin. You want to make sure you're measuring the correct vein, all these things, so you can give the patient the best option. Okay, and again, there are options if the patient doesn't have a big enough cephalic or basilic vein, or if there's superficial venous thrombosis and SVT in that vein where they cannot use the cephalic or basilic, the doctor can use a graft, which is a foreign material. It's a tube, basically, that you're going to hook in. You can see right here, they've hooked in to the artery at the mid upper arm, and then into the vein, the basilic vein, at around the armpit area, around the axillary area. So it is an option if you don't have a basilic or cephalic vein that's big enough or good. You can use a graft. However, it is always better to use your own cephalic or basilic vein as opposed to a graft, because it's going to last longer. Studies have shown when you put a graft in a foreign material, it's typically not going to last as long or be as successful as your own using your own vein. So again, we're checking for, is this fistula or graft when you scan it? Is it aneurysmal, a pseudoaneurysm, leaks, fluid, thrombus, all these things? These things can get really big. They can get kind of nasty. They're going to leak a lot because they're getting stuck 3 times a week at dialysis. It is a big, to have a fistula, it's a job. I mean, it's a big job. It's really difficult for the patients. Again, it's their lifeline. I think probably most places aren't going to do these. The Nortons probably will. UK, you're going to scan them. We do them in our office, but a lot of places are not even going to do these. So you may or may not even see a fistula. I don't want you to stress. This is very confusing. I don't want you to stress too much on this. I just don't want it to be foreign or you to never have heard it if you do go to UK or one of the bigger hospitals that do them, okay? When you get there, they will explain the protocol to you a lot more. Just know that a fistula or a graft is going to be a connection between an artery and your vein for dialysis, for the patient to successfully get dialysis. All right, and again, we're going to do peak systolic velocities on these. You're going to check for occlusion sometimes, and this is why when I have one of these patients, I always feel with my hands first to see whether I think, is it a basilic, like more on the inner arm, the medial, or is it cephalic? Is it more on the outer arm? I feel to see if I can feel the thrill. The velocities are very high through these fistulas. Excuse me. So you are going to be able to feel the blood flowing through there. It's very superficial. You're going to feel it. If a patient has a fistula and I don't feel that, it's probably occluded, as in it has clotted off. There's no blood flow, which is very unfortunate, but it does happen often. So you will just document that, put your color Doppler on. Remember, if you are not getting blood flow, what do? Turn your color scale down, turn your color gain up, document there's no flow. But again, if you're not feeling a thrill, the velocity moving through there with your hands, it's probably occluded. And again, volume flow, it's something the machine's going to calculate for you. Your clinical site can tell you this, but the machine's going to calculate it for you. Over 600 on volume flow is normal, and that is really and truly what our doctors are looking at, is what they're really concerned, what's the volume flow. The most common sites for stenosis on these fistulas and grafts are at the anastomosis on the venous side. And again, anastomosis is where they tie in vein to artery. And this is what they look like. I mean, this is kind of unimpressive. It just looks like a vein. It really is. It looks like a vein. It's very close to the skin. It's superficial. But when you put your color on, it's going to look like an artery more so. It's a very turbulent flow, but it will be arterial. But it could fool you for a vein until you turn your color Doppler on. So you're going to have a lot of blood volumes that are shunted from the artery to the low resistance venous system with this. Increased venous return can cause congestive heart failure. You can have steal syndrome, which is where the fistula will steal blood from your distal arteries, like your fingers. This happens a lot too. So the fistula will steal the blood from the hand, and patients will have white, painful, cool fingers. So we will take on that, a lot of these patients will take the arterial machine and use those little PPG photo sensors, check for pulses in the finger to indicate, okay, is this fistula stealing too much blood from the hand? Because that's a problem. They'll have to go in and fix that. And number one, I really should have started this lecture with this. This is one main reason why we always ask when we're doing an ABI or segmental, can I take a blood pressure on both arms? Please always ask every single patient, can I take a blood pressure on both arms? Because if you take a blood pressure on a patient with a hemodialysis fistula or graft, you could potentially occlude it. That would be devastating to this patient. Again, this is their lifeline. A lot of vascular patients will have these, and you do not want to be the one to occlude it. So if they cannot speak to you, again, they should have a bracelet on or a band that says do not take blood pressure. If they are able to speak to you, always, always, always ask. If the patient can't speak to me and doesn't have an armband, I always just feel the arm for a possible fistula just to make sure. Okay? Please and thank you. Do not be the person to take a blood pressure on a fistula and occlude it. Okay. So again, we already talked about this. So possible Steele syndrome. We'll use the PPG, the photosensors that we use for the toes and the fingers. We'll put those on the fingers to check for flow. And then page 125. Okay, yeah, 125 is going to show you the digits. Your fingers are going to be the same as your toes. You're going to want that dichrotic notch. Okay, and this is something that's pretty cool. I've not seen it done. I'm not sure anyone does it, but we'll cover it really quickly. So brachial artery reactivity testing is a possible marker for assessing cardiovascular risk. It's going to use the duplex ultrasound to evaluate the endothelial function. You're going to assess the ability of the endothelium to regulate vasodilation by measuring the degree to which the brachial artery dilates in response to reactive hyperemia. Endothelial dysfunction correlates with a higher than normal incidence of long-term coronary events. So reactive hyperemia is induced. What you do is you're going to inflate a cuff on the forearm to 250, which is very, very high. This is going to be very painful for 4.5 to 5 minutes. I really don't think this is going to happen, but it might. The diameter of the brachial artery that has a healthy endothelium should increase by greater than or equal to 10% when the cuff is on the upper arm. When the cuff is on the forearm, the increase should be at least 6%. So they're saying when you inflate that cuff, your artery should dilate. If it doesn't, that could indicate cardiovascular risk. Okay, I doubt anyone is using it, but you might see it. So if you do, let me know.